Good morning. This is Dr. Paixao and Dr. Lendel. We're going to discuss this exciting new technique which we've done a few years ago. And Dr. Paixao will introduce us to the technique.
Hi, I'm Dr. Paixao. I'm an interventional cardiologist here. I thought it would be good to kind of try to visualize this before we get into the case, because it's a pretty revolutionary concept. It's not the way we're used to treating these lesions. So I'm just going to briefly describe what we're trying to accomplish, and then you're going to go over watching me and Vasili struggle through it. So this is a procedure to treat long lesions in the SFA. So these long lesions, they tend not to do great with bypasses, well, with stents, and bypasses are sort of invasive procedure. These patients tend to have a lot of comorbidity. So we're trying to percutaneously construct a fempop bypass, basically. So in red, you see the SFA. In blue, you see the vein corresponding to it. What we're going to try to do is use catheters, wires, and needles to go from the artery before the occlusion into the vein, travel through the vein all the way past the blockage, then cross back into the artery. Once we constructed that channel, we'll park self-expanding stents that are covered. So basically, the equivalent of a synthetic fempop bypass, but with covered stents. So we don't run long on time. Let me start the movie of the procedure itself now. Yeah, I think it's going to play.
I see. So the first step of the procedure is to find a vein in a leg, suitable size vein, so we could visualize and make sure that the vein is good and healthy. And right now you could see exactly that. It's a femoral vein which filled with contrast, and it's a retrograde contrast filled in the healthy vein.
And this step is unique to this procedure. I mean, nothing else we do in the lab would necessarily be obtaining venous and arterial access for PAD patients.
And of course, obvious concern is that now you have a problem with the patient who has a stenosis in the femoral artery, but now we're going to utilize the vein as a conduit for a bypass. Therefore, patients, I mean, everybody going to ask, now we're going to create a second problem of potential DVT. And we'll talk about the data, real-world data later on how many actual DVT occurs, but that's why we need to make sure that the vein is adequate size and healthy.
And now we have arterial side on the other groin. We're going up and over like we would in a PPI procedure. So we're getting our equipment delivered to the SFA just before the blockage. The catheter that Brandon is holding here is the crossing catheter. That's going to fire the needle to allow us to go from the artery into the vein before the blockage. You see the angle of the camera there is not very user-friendly, and that's one of the problems with this procedure. It requires us to position the II, the image intensifier, at odd angles.
The two markers you see is the is a retrieval device which is placed in a vein. It's also that to introduce retrograde, and now you'll see a needle being delivered antegrade from the femoral artery. And the concept is a surgical concept. Instead of going through the disease, why not to have a conduit around the diseased vessel? And that's why PQ idea was born.
We're
talking about and discussing. The concept is right now will be to advance a needle from the artery into the vein and introduce a wire, capture that wire, and pull it down into the distal segment of the vein. You'll see it in a few moments. Right now, this is the advancement of the needle, and the basket will open.
On the left side of the screen, you have the crossing catheter with a needle that's in the arterial side. On the right side of the screen, you have what's going to be our retrieval basket. So we're going to expand that. We're going to fill the vein with this a metal cage. We're going to fire into that, and with the cage and needle, hopefully successful, create a communication between the artery and vein just before our long SFA occlusion.
It has been already 20 years since endovascular revolution started, and endovascular procedures became possible. In the beginning of the 20 years ago, the difficult part was to get across the lesion. That's where most people will spend hours and hours trying to get the proximal cap and distal cap. Since we overcame this and it rarely become a problem nowadays, the main problem right now is to keep the stents open. And you could see this patient already had several procedures done prior, successful, but there is a stenosis. You see a stent in the middle of SFA, which is closed.
And that's the arteriogram before we did it. So you see it's a very long occlusion. Almost the entire SFA is occluded. There's a stent there that's been placed and occluded, unfortunately, shortly after her initial procedure. And that's our target recrossing area. So that's where we're going to try to get back into the artery after we travel through the vein.
And the challenge right now, if even the best circumstance of the stents in SFA alone, especially in long occlusions, patency rate is dismal and around 50% in a few years. And it's a major struggle right now. When we see patients with occluded stents, we kind of say, okay, we expected that result. And the technique we describe right now and we show is free of any restenosis. The stent is covered stent, and it's very durable material because it provides very high radial force. We're going to go through all the layers of the artery into the vein, and so the stent will be subjected to the force of the muscular layers as well as all the tissue between the vein and the artery. So the stent is highly durable, and you could see right now that the basket is being opened. And
that's going to be our target. That's what we're going to aim for when we fire the needle. I think this was the 6th case we did as part of this study, so it's relatively early in the experience with this. They've changed the equipment and the technique a little bit to make it less cumbersome, to reduce the number of steps, and to reduce the need of these very extreme angles with our image intensifier. I mean, Vasili and I exposed ourselves to quite a bit of radiation doing these early procedures. He doesn't care, but I do.
Typically, Russians will tolerate radiation fine. we get stronger.
You were in Chernobyl, right?
Yeah, close.
So we're overlapping now our crossing catheter and our target basket. We're going to go 90 degrees from that and try to fire the needle into our cage.
And let's see. Should we speed it up? Here you go. You'll see right now the needle being fired. And the first trial, the first feasibility trial was done in Europe. 77 patients were enrolled. It was a safety trial. We were part of the larger trial in the United States called Detour 2. And in that trial, around 202 patients with a follow-up at 3, 6, 12 months, and 24 and 36 months. And then we'll go at the end of the conversation of the data so far, but the trial lasted for several years and it's still going. We completely recruited, and now the trial was submitted to FDA for the final approval. Here we go. You saw the needle being fired into the basket. Then that's from the artery into the vein. Then the wire will be introduced.
And this is a very robust needle. There are some kind of re-entry devices that can be used for more traditional peripheral intervention procedures, like an Outback device. This needle is sort of twice as long, very sharp. We're trying to really go through all the layers of the artery, which is the opposite of what we're trying to do with the Outback and other things like that. So it's pretty unnatural to kind of fire this into someone's
and you
artery.
Could see, you could see now the wire travels down in a second, and
yeah, we're trying to make it sort of go more naturally into the vein. There we go. Now we know for sure we're in the vein. We're going through the struts of that retrieval basket. Vasili is withdrawing the needle a little bit, and then we'll capture the wire.
Good. So that we should maybe move it forward. Can we move it forward?
I think we can. Yeah, that way. If you drag it like this, I think it speeds up.
Here we go. And now, obviously, now this is it. Yeah, here we go. The wire has been retrieved, and the next.
We got this wire just all the way outside the patient's body through that vein. So now we have a pretty straight rail that will allow it to cross back. So that's it. That's the wire being dragged back through the vein, and it's going to come all the way out the sheath that we put in the posterior tibial vein.
Mm-hmm. And the next step is most interesting step, because you could realize now we're going, initial step was going from a very small space to a very large space, very easy. But now we're going to go the opposite. We're going to go from the large vein, which is 10, 12 millimeter diameter vein, into a popliteal artery, which 4, 5 millimeter in diameter. So the trick will be to get from the large space to small space with this large needle. And the more tries you have, the more difficult it becomes, because the needle is fairly large and you could create a significant hematoma. But
yeah, so now the wire's coming out the leg. It's going sort of around from one groin axis all the way out to the vein on the other side. I think some of it is playing back because they had to break and go to the OR while we did part of the procedure. So that's why we're going through some of those images again.
This is a dilation of the proximal part of the graft, and you could see the waist in the balloon where we dilate the channel between the artery and the vein. And then we'll go and deliver the needle in the vein, and we'll and that needle will go, yeah, here we go. That's its channel.
Yeah.
Here we go. Now the needle went from the vein into the artery. We'll slowly withdraw it, and you will see an arteriogram will show us the artery in a second.
Yeah, this time we don't have a clear target like we do for the proximal crossing. We're basically going to do an angiogram and hope that we have enough opacification of the distal artery there. And we do in this case. You see where the needle is supposed to be. So Vasili is pulling it back. Once we believe we're in the lumen of the distal SFA, we'll try to advance our wire.
Okay. And then afterwards it's a home run. Then we'll
That's a
dilate
big
the
fast
distal.
forward. That was probably half an hour of us struggling there.
Now we could see the arteriogram showing contrast in the vein, in the venous space. Then we will deploy stents.
Yes,
and
at this point we have our whole tract constructed already. We have a wire going from the proximal SFA into the vein, back down to the distal SFA, truly bypassing the blockage. And once we've dilated both crossing sides, we start deploying the covered grafts.
Economics of this is also interesting, because if you take an artificial bypass graft, they're around $10,000. The stents available currently in the market, the Gore stents, Viabahn, longest stents cost $8,000. You could imagine how this stent's only a third price of those stents. It has a better radial force. It's a covered stent. So essentially the same concept as an artificial graft, but way, way less expensive. So economics is also quite favorable. You could see how easy to deploy this stent. And now we're going from the artery, borrowing the space in the vein.
And we're going to end up using 3 covered stents for this. So we'll use 3 of these. We wouldn't have used 3 of the Viabahn as well, but you see a little waste on the stent there, and I think we'll focus on that in a second. And that's the deployment system. You basically turn that knob, and it releases the stent.
There you go. And the data on the final trial of the tour, which we're happy to be part of, shows that 87% of patients had symptomatic relief at 2 years, and the primary patency rate for the stents, 79% at 2 years so far. And the dreaded complication of DVT, what we always afraid in the beginning, turns out to be at 2 years only 2.8 to 3%, which is very acceptable and clinically typically can be treated and has not resulted in any long-term consequences.
This patient actually had a DVT, but after 3 months of anticoagulation, it resolved, and she remained free of venous thrombus for the subsequent 2-3 years now, right?
Yes. And now we see, this is a final arteriogram, which will demonstrate in
I think we're showing here that the proximal struts of the stent actually go above the profundum. Those proximal struts are open, not covered, and we kind of want it there to make sure we're excluding all diseased SFA from blood flow.
And you could see very normal, very good, very robust and brisk distal flow for the bypass. Very laminar. The stent is well expanded, and it takes a shape of the vein without being compressed. And the whole physics of that is stents which are fully expanded will be less likely to cause thrombosis or less likely to cause a problem later on. Took us an hour and a half, 2 hours to do?
Yeah, in these early cases, I think we would take longer, but later in the trial, I think we were finishing this up under 2 hours.
Patient went home next day, went to return to work on Monday, and no prolonged hospital stay, and remains symptom-free.
You have any questions? No, Vic is clapping, so.
There you go.